Hi, guys, and welcome to Chapter 14. Today, we're going to be discussing epidemiology. We're going to talk about what that means in a moment. These are learning objectives for the chapter. So these are what you want to study in preparation for the exam for this chapter. Epidemiology is the study of how diseases are spread and experienced by populations. It usually takes basically heed of how the spread, progresses throughout a population, and the patterns that it follows within a population. And we can learn more about the disease and how it spreads based on the data that epidemiologists collect. And it's largely data based. Start off with this little story of Florence Nightingale. She was considered the mother of nursing, and she basically used epidemiological data to implement changes in how things were managed in hospitals during the Crimean War. And so she noticed that 32 out of every 100 soldiers were dying in field hospitals, mostly from dysentery, which is completely unrelated to the wounds that they were getting. Dysentery is like oral fecal transmission. So she instituted some changes that improved the unsanitary conditions to make them more sanitary at those field hospitals. So then less people were dying as a result of the practices in place. And this was very data driven. It was health, disease, and statistics based information that led to the changes in these fields. She's considered the mother of nursing, but she has a huge part to play in the statistical analysis of situations and making changes based on those statistics. John Snow was more of a field practitioner of epidemiology. And basically what happened, there was a cholera epidemic, and cholera is a fecal oral transmission disease. It's a diarrhea disease. And he mapped out cases of cholera in London. Basically, they were clustered around water pumps. And so he basically had the water pump handle removed, and lo and behold, no more cholera. And so just by mapping out all the cases of cholera in the area, he noticed they were all using the same water pump, removed the handle, and then no longer did they see spread of cholera. So he is considered sort of a father of epidemiology. So Florence Nightingale and John Snow are our biggies in this chapter. All right, so here are some terminology. This is a pretty terminology heavy chapter, so please buckle in for me here. Prevalence of disease is the total number of existing cases with respect to the entire population. So the total number of cases in the entire population during the outbreak, okay? If we're talking about the number of people affected in a specific time frame, that's incidence. So how many cases this week? How many cases this month? That's incidence. And it's very similar to the morbidity rate, okay? So incidence and morbidity rates. How many people got sick this week? How many people got sick this month? That's the incidence. Whereas prevalence is, again, the total number of existing cases in the entire population. Not this month, just the total number of existing cases. Total number of existing cases. Incidence, the number of cases in a certain time frame. Mortality rate is the death rate of the population from the disease. These are all figures that we can use to basically analyze data in an outbreak. And this gives us some examples of some curve patterns that we can see associated with certain outbreaks. But we need to understand more about the concepts than identifying the curves, because I'm not as likely to bring it up as I'm not as likely to bring that up as a picture of a curve. I want you to understand what the curve represents. So a point source epidemic, the infectious agent came from a single source. All victims were exposed at the same time. So the key here is one point in space and time. A literal specific time that everybody was exposed, and a literal specific place that everybody was exposed. If I come in coughing into the classroom and I have COVID, and you all get COVID from me, that's a point source epidemic. A common source epidemic is a single source, again, so still source based, but it's not at a specific point in time. In this case, it's over a period of time. So when we talked about John Snow's outbreak of cholera, people were using that water pump for weeks. And over weeks, it was a common source, but it was not at a single point in time. So that was a good example of that. So if you guys came to, the science building and people were getting sick for weeks after being in the science building, and lo and behold, we realized it's a special mold that was growing in the ceilings or something, and everybody was getting sick from that over periods of weeks, then that would be a common source epidemic. It's from one source, but over a long period of time. The next group, the next type of epidemic that we can see, the next type of outbreak is the propagated epidemic. In the propagated epidemic, these are outbreaks that are maintained in the population. It might fluctuate within the population, but it's generally maintained over time in a population. Okay, so cold viruses, for example, we might see them increase in number and frequency in the wintertime. But generally speaking, is it that weird for people to be having cold at any given time of the year? Not necessarily. So these are things that are propagated by the population, kept existing by the population. So they're propagated over time and maintained within the population. We might still have fluctuations in frequency over time, but generally speaking, the human population is keeping it going. So that's the different types of outbreaks that we can have. Next, we have basically looking at how the outbreaks progress. The index case is the first person in a given outbreak that got sick. So we could track back COVID to the first person that got COVID and then spread it to the other people. That would be the index case, patient zero, if you will. Okay, the index case is patient zero in an outbreak. Anytime we use the term endemic is any sort of disease that is present at a normal level in that area. So, for example, if you go to, Central Africa, Sub-Saharan Africa, and they have malaria, that's pretty common over there. It's endemic there. If you come over here and you get a cold in the middle of the wintertime, endemic. It's at an expected level in the population. A steady frequency, an expected frequency in that particular geographic area. Okay. Sporadic is where you have a random outbreak of something, but it's not really maintained as an outbreak in the population. If we get a couple cases of people who get Ebola, somebody went to Sub-Saharan Africa, contracted Ebola, came to the US, and that person and maybe a couple healthcare workers got involved, and that would be sporadic. Okay, very random outbreak. If you get bitten by a rabid squirrel, then that would be sporadic. Okay. Once that is being kind of spread within a population, it is contagious and it is spread with that population beyond what is expected for that population, then that is an epidemic. It's a true outbreak situation where people are getting sick from each other and it is spreading beyond what is expected. That's an epidemic. Okay. Pandemic is when epidemics spread across continents. It doesn't have to be over the whole world. It just has to cross continents. Then it becomes a pandemic across continents. So for all of these types of outbreaks, we might use tests to determine what is going on. There is a difference between screening tests and diagnostic tests. A screening test is basically a quick and dirty way to see the likelihood that this person has a disease. They're usually, mildly reliable, but not entirely reliable, and they're quick and dirty. These are your home COVID tests. There's a screening test. A diagnostic test will typically be a little bit more invasive with more hazards, but they are usually more accurate. It says lower accuracy. Diagnostic tests have a higher accuracy. They're more reliable. So when this says have lower accuracy, what it's talking about is that again, how should I word this? Screening tests are different from diagnostic tests because screening tests have a lower accuracy. Diagnostic tests have a higher accuracy. It's the wording in this that I find weird, but yes, diagnostic tests. Which is more accurate? Your home COVID test or the PCR test? The PCR test is a diagnostic test. The home COVID test is the screening test. Usually a quick and dirty way to check throughout the population to screen them to see basically the prevalence of this illness. Not entirely reliable, but it can give you a general sense of things that are going on. Common screening test is the pap smear. It is not diagnostic. If you have abnormal cells in a pap smear, does that diagnose you with cancer? No, but it lets you know that you should do diagnostic tests for cancer if your pap smear is abnormal. So we get the sense there. Pap smear doesn't diagnose. It tells the doctor that you should do more specific testing to see if something is concerning there. So that's a great example of a screening test, a more general kind of screening test. To look to see, do we need to do more specific tests? Because the specific tests can be more invasive, like a colposcopy or a biopsy, something like that, if we are worried about cervical cancer, whereas the pap smear is just a little brushing of the cervix. All right, quite different. We basically look at the accuracy of screening tests in two different ways. How specific is it and how sensitive is it? I'm going to start with sensitivity. If you're a very sensitive person, you'll pick up on any tiny little thing, and that's what this means here. The more sensitive you are, the more likely you will say this test is positive, even if you have only a tiny little bit available. More likely to say it's positive when it is even very small positive. And therefore, sensitivity, which has an N in it, the more sensitive you are, the less likely you're going to have false negative. The more sensitive you are, the less false negatives. A false negative is when you say something is negative, but it was actually positive. How many times have you guys thought, like, you take a home COVID test and it tests negative, but you're pretty sure that it's positive? Or you take the PCR test and it ended up positive. That was a false negative on that home COVID test. So it's not uncommon. The more sensitive you are, the less false negatives. Okay. For specificity, this is determined by how many people we're calling positive who are actually negative, the false positives. So what this means is if you take like trying to think of a good example, if you take a drug test for methamphetamines and you got a positive result for methamphetamines, but you've never taken a methamphetamine a day in your life, you've never done illegal drugs or whatever, but you got a positive test for methamphetamines, but you took, Sudafed the night before, you could test positive for methamphetamines on your drug test. That's a false positive. So we want our tests to be specific for what they're testing for and not have any overlap. So again, the more specific, you will have less overlap with other things. This is where when we call something positive, we mean it's positive. So it has to deal with the positives. Again, specificity has a P for positives. We want to see that our true positives are really positives and then less likely to have false positives. I could spell it correctly. We'll have a decrease in the false positives. Again, false positive is saying somebody's positive for something when they're not. So don't look at these as competing characteristics. We want our screening tests and our diagnostic tests to be as specific and sensitive as possible. So they are not warring traits. They are things we want, both of these things. Okay. How sensitive is basically going to pick up on any little positive at all. If it's even slightly, even if there's even one virus there, again, we can look at it this way. Which is more sensitive, the PCR test or the home COVID test? The PCR test is more sensitive. You can pick up on even just one virus. More sensitive. More specific. We want to be sure that if it says it's positive, you actually have the disease that you're testing positive for, not something that looks like it, not something that's just accidentally tripping it as being positive. Okay. So that's specificity. Okay. So what's causing our outbreaks? Again, this comes back to Koch's postulates, which we talked about in chapter 13. We can use Koch's postulates to identify microbes. We have an illness. We can isolate the organism, prove that this is causing it by putting it in a new host and then pulling it back out again and saying, yep, this was the same organism. That's Koch's postulates. We can also use molecular techniques like PCR and genetic sequencing to determine the causes of outbreaks. Basically, all of this has to track with the same disease and all of this stuff. So we can't do human trials on disease. So we usually use animals as a way to mimic this stuff in our studies. But if we can't do that while we have an active outbreak going on, then what we can do is observe how things are behaving in human populations using clinical trials. So randomized control trials, these are types of studies that are done basically to look at a random group of people and comparing them with people who are exposed to the illness or not, or have the treatment or didn't have the treatment. These are the randomized control trials. And there's different types of studies that we can do to track our outbreaks. In the cross-sectional studies, we have two factors that we'll be looking at. For example, were you exposed? When your professor coughed with her COVID, were you exposed to that COVID? And did you get the disease if you were exposed? So we can look at that stuff. The key with cross-sectional studies is that we are looking at a single point in time. Right now, how many of you are exposed and how many of you have the disease? And we're not trying to determine, were you exposed first? Or did you have disease first? Or, at what point did you get the disease after? We're not looking at that. We're just seeing how many people were exposed and how many people have the disease at a single point in time. Whereas a case control study, we are comparing cases, people that have the disease versus people that are the control group. That's people that don't. So literally categorize people at first. Do you have the disease or not? If you have the disease, tell me this data. If you don't have the disease, answer these questions. And we can compare those groups to each other literally based on cases versus control group. Don't have the disease. Okay, so people that have the disease compared to people that don't have the disease. That's the case control study. And then we also have the cohort study. This is taking people that don't have the disease, and it's usually going to have two groups. We'll have the risk and the no or low risk group, and track them over time, usually years. So we have a group of people that smoke and a group of people that don't smoke. And we follow them over time to see which group gets the most cases of lung cancer. That would be a cohort study. So cohort studies happen over long periods of time. Cross-sectional studies are at one point in time comparing two data sets. Case control studies are literally control cases, people that have the disease versus control group no disease. And cohort studies are looking at over time, do they get the disease, tracking over time. And usually it's a risk versus a no risk group. So again, women that have genes that predict for breast cancer and women that don't, we look at them over 10 years. If the women that have that gene were more likely to have cancer, that's a cohort study. So we collect all of the data that we need over these diseases to basically study how the diseases are spread and things like this is through surveillance. This is collecting and analyzing all of the data related to the disease, whether that's the prevalence or the incidence or the death rates and all this stuff, and performing surveillance in larger communities or in smaller groups, depending on the size of the outbreak and whatever sets of data that we might need to track the outbreak. There are some diseases that are reportable by law to authorities. They could be reportable to the World Health Organization or to the CDC or to your local government, depending on whatever they're tracking. When we report diseases, this could be at the local, district, state, or national, or even international levels, depending. So physicians and hospitals will report all those diseases that are brought to their attention, and then depending on whatever the disease is, they might need more data or reports based on what's going on with the disease and things like that. And that helps us generate our morbidity and mortality report for the CDC. So it's a weekly notice of diseases that are reportable and their progression. So we can keep an eye on, are these diseases spreading more or less? And in what areas are we seeing increases or decreases and things like that? Some diseases are more closely associated with healthcare situations. So being in a hospital can actually make you more likely to experience certain types of diseases, including things like catheter-associated urinary tract infections, central line-associated bloodstream infections, surgical site infections, and ventilator-associated events, often respiratory illnesses associated with being on a ventilator. And so we have medical professionals at hospitals and like infectious disease specialists that are usually going to be in charge of managing this for the hospital level. And there are rules in place for medical asepsis, surgical asepsis, and the infection control. The infection control officer is the one that's basically going to dictate that and track that throughout your hospital and put precautions into place. Like if you're entering a room for a patient that has C. diff that you have to gown up and glove up and things like that. That would be medical asepsis. And then keeping sterility in a surgical field is surgical asepsis. All of those rules and things like that are managed by the infection control officer within a hospital environment. Again, medical asepsis, this is going to be things like whether you should wear PPE in certain places, and even things like proper hand washing and disinfection of places between patients and stuff like that falls into medical asepsis. Anytime that we need things to be as sterile as possible in a surgical environment, again, different kinds of rules, surgical asepsis, as close to sterile as possible for that. And your infection control officer at your healthcare setting is the one that basically puts all of those proper procedures in place for your hospital to make sure that you are in line with, local laws and federal laws and things like that, as well as controlling local outbreaks or breaches in asepsis and things like that. When we're tracking outbreaks too, many times our illnesses, we have the ability to kind of track how an illness is going to be spreading. And each pathogen that we're looking at has a specific R naught, R sub 0, also referred to as R naught. This is a term for the basic reproduction rate of a pathogen. So each pathogen has its own R naught, and it describes how many people an infected person is likely to infect. So generally speaking, for COVID, R naught is about 5. That means that if you get COVID, you're likely to infect about 5 people while you're infected. That's the R naught. The case fatality rate, or CFR, is the number of people who die from the disease divided by the number of people who are infected. Looking at basically, it's a ratio. If you get infected with the disease, if you're infected, what's the likelihood you're going to die from it? That's the case fatality rate. Again, you have to be a case, you have to be infected. The fatality rate of the infected is the CFR. But there's one key thing about this. It's not just any people who are infected, your likelihood of dying. It's those who receive no treatment. This is a baseline for people who receive no treatment because not all local areas or hospitals or communities have access to health care. And so this is a baseline based on no treatment. So this builds us a little graph based on R naught and CFR, case fatality rate. So again, the deadliness is the case fatality rate, And here at the top, we have the most deadly. Rabies and HIV are considered to be 100% CFR, 100% chance of fatality if it's not treated. Case fatality rate, again, without treatment. But they're also not as likely to be transmitted. Rabies and HIV have a pretty low, are not. They're less likely to transmit from person to person. In fact, rabies is almost zero, somewhat or minimally communicable, versus measles, which is extremely communicable. Generally speaking, the more communicable, the more easily spread you are, typically the less deadly, because again, a pathogen that is very highly spread and kills everybody is usually going to be an issue for that pathogen being able to be spread from person to person. If it kills people too quickly, it can't be spread from person to person. So just keeping that in mind. So this is a sort of a relative thing. And again, CFR is based on treatment availability. All right, moving on. One way that we can control spread of infection is through vaccines. And one of the most important things about vaccinology is herd immunity. Herd immunity is the idea that when a significant portion of the population is vaccinated for a disease, that you can limit the spread of the disease within that population. You can achieve perfect herd immunity with many diseases based on the R naught. Again, if it's a very, very communicable disease like measles, the more people need to be vaccinated to protect those who can't or aren't vaccinated. Okay. So it's the idea herd immunity is achieved through having survived the disease or from being vaccinated. So many times you can get diseases and then have the protection in the future. But that's not always possible with all diseases. So vaccines are designed to try to trigger that memory without having to expose you to the risk of having the disease. Yes, are there risks involved in vaccines? Of course. But the risk of the vaccine should be much less than the risk associated with having the disease. So that's very important to remember. Again, the idea of herd immunity is that if we have enough people that are vaccinated, we can protect the people who can't be vaccinated from the disease so they won't get the disease at all. Then we're talking about diseases that can cause death and significant sequelae. Again, what are sequelae? Signs and symptoms that last after the infection is cleared. So we want to protect people from that sort of stuff, including secondary infections and severe illness that we might see with certain diseases. Globally, we are seeing emerging and re-emerging diseases. Emerging diseases are diseases that are new to the population. Even HIV is relatively new to the human population when we think about the whole history of humanity. But some other ones that are even more new would be SARS. COVID obviously is an emerging disease. And then each time that we have a new strain of flu, that would be an emerging disease. So new microbes that are new to your immune system are emerging diseases. Re-emerging diseases are diseases that we were waning off with, but now because of things like drug resistance or cramped populations, we might see them coming back out again, including things like tuberculosis, which is probably one of the most common of our re-emerging diseases. It's one that was pretty well controlled, but now we're seeing an uptick as we see homeless populations increasing and their lack of health care and their close living quarters contributing to that spread of that disease. Some other ones would be our neglected parasitic infections, which are significantly underfunded worldwide. And we do have some of these diseases here in the US, and even in the US, research into these diseases is underfunded, usually associated with poor neighborhoods or immigrants from countries where those diseases would be present. These neglected parasitic infections. Again, parasitic infections are infections that are caused by protozoa or helminths. So eukaryotes that are not fungi. Okay. So protozoa and helminths. This includes things like Chagas disease. Chagas disease is transmitted by a kissing bug, and we'll learn more about it in future chapters. But it is caused by the protozoa Trypanosoma cruzi. Then we have neurocysticercosis, which is also not that uncommon. It is caused by the tapeworm Taenia solium through undercooked meat products. And again, the tapeworm eggs can move, larvae basically can move into the brain and then cause headaches and neurological symptoms associated with that. Toxocariasis, this is toxocaria worms that can cause blindness that live in the eyes. Toxoplasmosis, these are protozoa that are very, very common in the United States, infecting 60 million people in the US that we know of. It's transmitted through like cats and cat feces and urine. So again, handling cat litter can expose you. And then trichomoniasis is probably the most common of all of the parasitic infections in the US. It is extremely common sexually transmitted infection, but it can lead to premature births in infected mothers. It can cause severe issues associated with that. So all of these are either protozoa or helminth infections that are here in the United States right now. That again, it's usually underfunded because they're usually affecting poorer populations. And finally, of course, bioterrorism is basically the threats of using any of these microbes for intentional killing of populations of people. Anthrax is probably the most popular of our bioterrorism threat agents. While we've had smallpox used as a bioterrorism agent and the plague as well, used bioterrorism agents, during the medieval and dark ages and things like that. More commonly in modern age, the bigger issue is things like anthrax or designed viruses and things like that, potentially affecting populations. Anthrax has actually been actively used as a bioterrorism agent. Again, dissemination of anthrax endospores can be, accomplished through things like the mail and stuff like that. And it was whenever there was, a bioterrorism event with anthrax to Congress in the United States, where somebody mailed anthrax to Congress, and so it's a big issue with that. So that's bioterrorism, and then more specifically within that sort of subset is agroterrorism. Instead of attacking the human population, attacking the livestock industry. And there are many viruses that are out there that would be devastating to the United States livestock industry if they were able to get into the United States. So microbes that are used to decimate the agricultural industry, especially the livestock industry, but it does include plants as well. So even like corn and wheat and things like that, that could be devastated by microbes. All of that would be considered agroterrorism. So that concludes chapter 14 in our study of epidemiology. Thanks for joining me, and I'll see you next time.